CTAC is nothing if not adaptable in its singular focus to transform the way we deal with advanced illness care in this country with justice and equality, diversity and inclusion. Tempered in this refining fire of the pandemic, CTAC is focused on the priorities that we hope will be shared and supported by all of you. In keeping with our new format and focus, we proudly present our opening keynote, presented by the dynamic Dr. Darrell M. Gray II. He's the Chief Health Equity Officer at Elevance, which most of you know as Anthem. To say that Darrell Gray is outspoken is a positive thing, a real strength of his. He has spent a career becoming the health equity champion, basing his work with sound clinical and policy footing that elevates the community and always focuses on creating better healthcare systems. Prior to joining Elevance, Dr. Gray was Associate Professor of Medicine at The Ohio State University. Ladies and gentlemen, please welcome Dr. Darrell M. Gray II.
Good morning, and first of all, thank you to the CTAC leadership and staff for the kind invitation and the hospitality. This is awesome. It is so marvelous to be in person again. I cannot adequately express how wonderful this feels to be at an in-person conference. Videographer, you're gonna have your work cut out for you because I cannot keep still. I'm gonna be moving around the stage. And Jayla, I want to thank you for that very kind introduction as well. You know, I get to wear, as Jayla said, multiple hats, and I get to serve in multiple roles, certainly not the least of which is Chief Health Equity Officer at Elevance Health, where we get to serve 45+ million members. We have over nearly 100,000 associates, employees within our organization. So it's a great place to be. It's a place that represents the diversity of America and our nation. But one of the roles, or two of the roles, that weren't mentioned in my introduction that are my most important roles are getting to be a husband of now 12 years and a father to 4 children. Thanks. And our kids range in age from 8 months to 7 years, so it's a busy, hectic household. But one of the most cherished times in our house is story time. And it's because of 2 things. One, it's just a great time of learning. And we have 2 school-age children, one in 2nd grade and one in kindergarten. So it's fun to see them learn during the story time and also reading as well. But a second reason is because it means that it's close to bedtime. Story time is always at night. And so it's a much welcome time of relief for my wife and I. And so now I'd like to welcome you, now my extended family, into our metaphorical living room. We're gonna have a little story time. Is that okay? All right. So Ephraim Johnson and Daisy Shelton were born in Fairfield, South Carolina in 1919 and 1923, respectively. And Ephraim attained a 3rd grade education and Daisy a 5th grade education before then transitioning to work in the fields, as they would say. They were farmers. And you can imagine being born in those years in the South, some of the challenges that they experienced in kind of their daily life. But they were overcomers. They were resilient, and they ultimately met each other, they got married, and they started to have children. And Ephraim ultimately left, and they left. They migrated up north to Baltimore, Maryland, so a neighbor to DC. And Ephraim got a job at Bethlehem Steel. I don't know if anyone in here remembers Bethlehem Steel. Raise of hands if you've heard of. Okay, so there are many people who know of Bethlehem Steel, but he got a job as a crane operator, and Daisy got a job at London Fog. Anybody remember London Fog that makes clothes? Yeah. So she was what was called a piece worker. That means that she got paid for every piece that she sewed. So she got paid 25 cents for every piece that she was able to sew. So again, they were resilient. They became homeowners. They raised 4 children. They got to see their children enter college, which was a kind of a distant dream for them, and graduate college. But in their later years, serious illness struck. And for Ephraim, that serious illness was strokes that left him somewhat debilitated, but more so advanced dementia. And for Daisy, it was heart failure. It was strokes that really caused, and emphysema, that caused really some serious illness for both of them. And it also became a situation where it was all hands on deck for the family. And so for their children, their 4 children, they were kind of balancing being caregivers. They would stay in a child's house for a couple of months and then another child's house for another couple of months. Some of you may understand that balance. And at the same time where they were juggling their own jobs, they were trying to be caregivers, they were also trying to navigate a very challenging healthcare system. And fortunately, they had a grandson, me, who was a physician and helped to navigate them through this healthcare system, but it wasn't always easy. And, fortunately, we were able to get advanced care planning, and we were able to get them the palliative care and ultimately hospice care that they needed at the time that they needed in the way that they desired to have it. And fortunately and unfortunately, it was a positive experience, but it was an exception because it certainly is not the rule. Many of you will appreciate that there are many people who cannot share that same story of a successful kind of palliative care experience, a successful hospice experience, a successful advanced care planning experience. And particularly as we think about those who have been marginalized, we think about, for example, communities of color, that experience of having a positive end-of-life experience or kind of navigating a serious illness is, for many, far out of reach. And it's no surprise. We think about African Americans as 50% less likely to engage in palliative care, as just one example of one group. We know that if we look at geographically, that the majority of hospitals that offer palliative care programs are in urban areas. So that leaves out some of our rural providers and rural caretakers and those living with serious illness in rural areas. We know that public hospitals are less likely to have a palliative care program. So these public hospitals are the safety net, right? And so we think about people who are living on Medicaid or people who are uninsured, who don't have access to palliative care or advanced care planning. That's the system that we live in. And I think about a statement made by Dr. Paul Batalda, and I think he may have said it first, that every system is perfectly designed to get the results that it gets. And so I don't assert that our healthcare system is broken. I think it's working perfectly as designed. And so as we think about what needs to be done, we have to redesign. And as I think about some of the disparities that we see in outcomes in care, whether it's based on geography, whether it's based on race, ethnicity, it's also what's been ingrained even in our future physicians. So there was a study, not done in 1816, not done in 1960s, not done in the 1980s, but in 2016, where it was a study done at the University of Virginia that assessed trainees, medical students, and residents. And the survey asked questions about false beliefs like the skin of Black individuals is thicker than that of white individuals. And they found that over half of these trainees subscribed to such a false belief. 2016 study. Not only that, 12% of these trainees suggested that the nerve endings amongst Black patients were less sensitive than those of white patients. So it's no wonder that as we look across our literature, we look across our landscape, pain is not managed the same amongst all groups. As a matter of fact, as we look particularly just as one example amongst Black patients, they have worse pain management as compared to other racial and ethnic groups. They are less likely to have a positive outcome in palliative care, in pain management, in hospice care, as compared to other racial and ethnic groups. And so as I think about the opportunity that lies ahead of us, we have to design for the outcome that we seek. And so one of the joys that I get to do at Elevance Health is to help with that redesign. And our strategic approach, we've coined health equity by design, because we recognize that health equity, which means when everyone has a fair and just opportunity to be as healthy as possible, won't happen by happenstance or chance or because we wished it so, but it'll happen because we were intentional, that we embedded it in our practices, our programs, and our processes by design, proactively instead of reactively. And so as I think about the things that we get to do, particularly in this space, and how we care for those battling or traversing serious illness, it's because we've embedded health equity by design into our ultimate success. And our health equity by design framework has really 5 main pillars. One has to do with getting to know our members better. So it has to do with how we collect and use member data. Now, there's data all over the place. If I go on Amazon now, Amazon will know what I need before I need it. It'll tell me what to order, and it get it there to me either today or tomorrow. But we have to know our members in ways that we haven't before to be able to tailor solutions in a way that's meaningful to them. But also, we have to be better partners with providers. That's the second pillar. Ensuring that we enhance the capacity of providers to deliver on our mission, vision, and values in advancing health equity, that we hold them accountable, but we also incentivize them to replicate the behaviors in providing high quality, equitable, timely, and safe care in the way that members and the caregivers deserve. We can't do this unless we do a third thing, which is continually challenging ourselves to cultivate a culture that will advance health equity, getting our own house in order. Ensuring that we, fourth, identify and scale best practices. We're not resting on our laurels with 1 or 2 successes, but we're continually trying to refine and evaluate our progress, abandon those things that aren't working in the way that we want, but continuing to innovate in this space. And also, driving fifth into ensuring that we continue to challenge what we say is affordable and accessible care, making sure we can make the right choice the easy choice, make sure we can make the right choice the accessible choice for our members and for our caregivers. And that's manifested in a couple of ways. We have a cancer care navigation program, we have oncology and palliative care solutions, we have a congestive heart failure, digital case management. All of these things allow both caregivers and patients to engage in a way that's meaningful for them, whether that's through an in-person interaction through someone like a case manager or a community health worker, or whether the caregiver prefers a digital solution where they can do it on their own time, but still engage with the live person. Look, throughout this conference, you are going to hear some dynamic speakers. You're all dynamic yourselves, and you're going to get a chance to engage with one another in conversation. I challenge you. You now are champions of information that you are going to hear throughout this conference, and I challenge you as you go back to your workplaces, as you engage with your own families, that you consider and just go back to the basics that I teach my 4 children: the who, what, when, and where. As you think about the solutions that you are devising for those whom you serve, whether it's a digital solution or otherwise, who's at the table in helping you to co-design the solution? Who is not at the table? Whose voice is not raised? Who could be left behind if that solution is deployed at the wrong time to the wrong person and to not the intended audience? What? The what is, what are you putting together? What are the potential unintended consequences of your solution? It's not always considered. When? When in the care journey is your solution going to be deployed, and what are potential adverse consequences of not doing something at the right time? And where? Where can people access your solution? How can they connect with people? Think about your own family. I certainly, as I think about what we are doing at Elevance Health, I think about Daisy and Ephraim. I think about my grandparents. I think about what made them have a positive experience, but some of the challenge they would have otherwise experienced if I, as a healthcare provider, as a physician who's familiar with some of the fragmented aspects of our healthcare system, cannot help them navigate. And that's what we all have to bring into our workplaces. Look, health equity is personal, and it's also everyone's business. Many of you might serve in large organizations where you have a chief health equity officer. You might have a chief diversity and inclusion officer. But know that it's not up to that one person to carry out the mission of advancing health equity. It's all of our mission. We cannot do this alone. And I had the privilege of meeting one of my Ohio State colleagues before walking into this ballroom today. And he would tell you that, we think we have the baddest band in the land. But one thing that I articulate across our enterprise at Elevance Health, and I challenge you to do, is that as we advance health equity, it is critically important that we be one band, one sound. One band, one sound. And I think what you're cultivating here at the CTAC Summit to take back to your individual workplaces, to continue to champion the work and advocating on the Hill and otherwise, that we are all one band and one sound in advancing health equity. Thank you. Look, this work is personal. This is our family, these are our friends, these are our coworkers, these are our people in our churches, in our social networks, and their families. And we are just one tragic life event away from being a caregiver ourselves, or being someone with a serious illness. Take that message back. As you think about what you're going to do to support CTAC, to support your caregivers, to support your members, to support the communities, near, far, diverse communities, particularly those who have been made vulnerable by systemic inequity, take this message that CTAC is doing today back to your workplace, and I thank you for your time. Thank you.